Good afternoon, and welcome to the third edition of RadHQ's Radiology Webinar Series. The series has been designed to allow radiologists to share solutions to problems that impact day-to-day operations, and in the process, hopefully provide ideas that help improve overall productivity and profitability. Today's presentation is titled Transfer of Power, the Radiologist's Changing Role in PACS Decisions, and will be presented by Dr. Murray Reicher, MD, FACR. Dr. Reicher is a founder and former chairman of PACS company DR Systems and is currently CEO of Synthesis Health. Dr. Reicher has been a radiologist for over 30 years and was the head of one of the oldest radiology groups in the country prior to his starting DR Systems and his current involvement at Synthesis. This presentation will last about 30 minutes, with 15 minutes or so reserved for questions and answers. If you have any questions, please put them in the Q&A box. It's the box that has the question mark next to it, and they will be addressed at the end of the presentation. And now, without further ado, let me turn it over to Dr. Reicher. It's all yours, sir.
Thanks, Mike. Pleasure to work with you, and thanks for all your contributions to making this webinar happen. Welcome to those of you in the audience. I appreciate you taking the time out of your day to share some ideas with me and hear my ideas of what I've learned about this industry over the last 4.5 decades, and specifically, over the last year or two as trends have begun to shift. We'll talk today about the radiologist's increasing role in making information technology decisions in healthcare in North America and Europe. Let me share just a brief outline so you know what's coming. We'll talk about the shortage of radiologists, some of the consequences of the radiologist shortage, the causes of the shortage and the potential solutions, so we can think logically through how technology can help solve the physician manpower shortage, some key trends in imaging workflow, and associated information technology, and then a look at how people used to buy and who's buying today. Have you heard? There's a shortage of radiologists. So we have about 30,000 working radiologists in the US today. Some people believe that we need as many as 40,000. We certainly do by the standards of work productivity of radiologists, say circa 2020. Remember that, back in the days of film, I would say prior to 1990 to 1995, a typical radiologist read 8,000 to 10,000 medical imaging exams a year. With PACS, radiologists essentially doubled their productivity, and yet the medical imaging industry has grown tremendously. We see growth rates in the range of 5 to 8% compounded annual growth rates for an extended period of time. The industry continues to grow. We're throttled in our growth primarily by the availability of radiologists and technologists, and this workflow shortage is just causing enormous stress in the system. It's delaying patient care. It's causing burnout in radiologists. We'll talk more about that in a minute, but suffice it to say, we have a huge shortage of radiologists and technologists in most of North America and Europe. What happens when you don't have enough doctors? One trend that we're seeing all over the country is that radiology groups are kind of giving up their least economically favorable contracts, and that's often hospital contracts, and the smaller the hospital, often the more rural hospital, is the most vulnerable. It's a huge problem for healthcare in America. And you can't really blame physicians that are overworked and on the threshold of burnout, or maybe beyond the threshold, for giving up contracts where they're maybe receiving 18, 20 percent of their billed amount. The next thing is we're seeing, of course, radiologists looking at more and more images. So docs are giving up contracts and they're pushing themselves to read faster. And this is compounded, of course, by the fact that we have more images per exam than we've ever had before. The timeliness of service is dropping. In my community, where I practiced in radiology here in San Diego for about 30 years, if you were 20 or 50 cases behind, that was a big deal. If an emergency room patient was waiting for a head CT for 10 minutes, that was a big deal. Today, in communities throughout the U.S., it's not uncommon for a patient to have to wait for a week, 2 weeks, maybe even a month to get a routine medical imaging study read. The timeliness of service is dropping, and it's dropping not just for the on-premises radiologists, the on-premise radiologists, which is becoming the minority of diagnostic physicians, but the timeliness of service is dropping for teleradiology companies too. People in the teleradiology business have never given such bad service and yet never been in demand. Another thing that we're seeing is long-standing radiology groups are falling apart. There's a bell-shaped curve of productivity in every human endeavor. There are people, in law firms, there's an old saying that, in a group of lawyers, there's finders, grinders, and binders. Different people have different skills. Some people are people, and they communicate well in a radiology group with referring doctors. There's some people that tend to handle the, conferences in a hospital setting. There's some people who have management skills and are great at supervising the technologists. But pretty much today, the only thing a radiologist is compensated for is putting his or her name on a report. And it's very easy for the people who are most proficient at that skill to say, I don't want to share income with people who don't have that skill. I have the skill set that actually brings home the bacon. And I can join a teleradiology group, read remotely, and if I'm productive, I earn more money, and I don't have to worry about my partner, who perhaps is keeping the whole practice going. But nevertheless, there's this sort of almost self-centered approach to radiology. And if you're in a 20-person group and the most productive 4 or 5 people in the group leave, it's very hard for the rest of the people to keep the group together. More and more radiology groups are going to their hospitals and demanding stipends because of the radiologist shortage to help fund certain segments of radiology that might, where the costs of the radiologists exceed the reimbursement. That might be true for interventional radiology, pediatric radiology, fields like that. The next thing is that stress doesn't make people kinder to each other frequently. And we're seeing that not only are the fields of interventional radiology and diagnostic radiology diverging from an academic and training viewpoint, but economics are driving interventional radiologists and diagnostic radiologists into separate organizations as well. And this is causing radiology groups to change in structure. And at the end of the day, this is a flywheel problem, because it all starts with we don't have enough doctors to go around, and it ends with we're going to have even less doctors to go around because radiologists, as a consequence of all of this, are burning out at a faster rate than they ever have before. Just some headlines from our recent literature. Long-standing groups. I know I live in Southern California, as I've mentioned, and here, I know 3 or 4 major hospitals. These were places that were plum jobs not very long ago for radiologists that have lost their radiology group because the radiology group just could not read efficiently at those facilities. And radiologists had other alternatives where they could read more efficiently with less stress and more income. I mentioned one of the consequences of this shortage is that radiologists are burning out, but a consequence that is even in many ways more disturbing is that where there are shortages of radiologists aren't reading exams. So this article came out of the Harvey Neiman Health Policy Institute of the American College of Radiology. And what they found is over a 10-year period of time, the prevalence of non-physician providers reading medical images doubled. Now we can expect that that trend might continue. And it's fascinating to me that radiologists in some cases are fearful of artificial intelligence kind of taking over their job. But what we also need to be aware of as radiologists is non-radiologists taking over our jobs. If there's no radiologist around to read the chest x-ray, somebody else is going to read it, and it might not even be a doctor. What the study found is that in essence, this is a recap, so it's not perfectly correct, what I'm about to say, but it generally is true that if you look at it state by state, the greater the shortage of radiologists, the more likely it is that a radiologist is not going to read your imaging study. And it's particularly a problem when you look at imaging provided inside of primary care and orthopedic surgeons' offices. And remember, a lot of imaging is done in the U.S. in other specialist offices today. And there, the likelihood of a radiologist not being involved in the reading of a case is skyrocketing. That's a problem not just for radiologists as a kind of a professional business unit, but it's a problem for quality, right? Because radiologists are trained to read medical images, and reducing the quality of the reader reduces the accuracy of the test and the quality of the product that ultimately the consumer is buying. I mentioned service dropping. Again, another headline. It's happening all over the country. Patients get imaged and then they wait to get a report, and that wait used to be in minutes and now it can be in weeks. Burnout. Radiologists rank 7th in burnout rates among the 29 physician specialties. So we're not at the top, but we're climbing a chart that we don't want to climb. Over half of radiologists report symptoms of burnout. And most of them say that their burnout is moderate to severe. 1 in 5 respondents in this particular study reported that they were self-medicating with alcohol in order to cope with their depression, which is a terrible strategy, of course, because alcohol is a depressant itself. So what do you do? In order to solve a problem, you begin by understanding the causes. And then you got to open your mind and look at each cause and say, is there a solution associated with this root cause? So one of the causes of this short, more work than there is staff to do the work is the aging population and the fact that people are surviving chronic diseases today. We're turning once fatal diseases into chronic diseases. And unfortunately, the solution to that is, what are you going to do? Let old people and sick people die? I don't think so. One of the causes of this explosion in medical imaging is that we have new imaging technology. It's a field that lends itself to innovation, and we just keep inventing ways to have medical imaging help people in healthcare. And it really kind of began, I think, in many ways with the CT scanner, which was, I would think anybody would have to list as one of the top 5 inventions of the 20th century. And yet, are we going to stop that? Are we going to stop inventing better imaging technology? I don't think we are. I think we're inventors, and we're just going to keep coming up with better and better ways to diagnose people non-invasively through medical imaging, and more ways to treat them. That leads inexorably to an expansion in the indications for medical imaging, and we're not going to solve our high demand for radiology by stopping the expansion of indications. That's not a solution. There are some people that think, hey, you know what the solution would be? Let's just cover less people. Let's take an ever-growing percentage of our population and make medical imaging unavailable or unaffordable to them. But we're going in the opposite direction, right? We're insuring more and more people, and despite transfers in power in Washington, it seems unlikely that we're going to cover less people, particularly as the people who need health care, which is seniors, more and more, become the predominant voting population in the country. Okay, we could utilize medical imaging more intelligently. There's no question about that. But after, managed care started around 1988 in the United States, and, it's been almost 40 years. Seriously, utilization management is not going to quash the demand for medical imaging. It's just not going to. So what are we left with? We can expand training programs, and we should, but that's a very slow process that may take a decade or more. And the last option is we can employ technology and business process strategies that help people work more productively. So that's what I want to talk about for the rest of my time here today. AI alone is not the answer. There was a very topical study that came out a few weeks ago in the JAMA Network Open Journal. It came from China. I didn't realize how many radiologists there are in China, and this study is not all of them, obviously, but there was a study that involved nearly 7,000 radiologists in China. They were given various types of psychological testing to determine burnout, and they were assessed after the use of AI. And what they found was, surprise, AI increases the stress of radiologists, doesn't decrease the stress in this study. To me, not that surprising a finding. And that reflects the nature of the AI we have in radiology today. So if I have 2 friends and one of them has no assistants and the other friend has 100 assistants reporting to her, who's more stressed? Right? The person with the greater number of helpers is always the more stressed person. And that's because most of the time, people that help you have to be managed. They don't complete tasks completely, and they don't do it autonomously, and they want stuff from you, and oftentimes they distract you as well. What we know about people, it's true for AI as well. So if I want a human or an AI assistant to truly help me, the assistant has to complete a defined task for me entirely. Has to be reliable, accurate, friendly, affordable, and not require my micromanagement and not interrupt me at the wrong time. A human assistant that can bring me a cup of coffee, and it's always hot, and if I take cream, it has cream in it, that's useful. If 20% of the time the coffee is cold or doesn't have cream in it, I might as well make it myself. An AI assistant that is like my mother standing behind me saying, Murray, you might have missed that, you might have missed this, you might have missed that. It may be helpful, but it's annoying. And I think that's a really critical insight for anybody planning to adopt AI as a solution. Adopt the solutions that complete a defined task that you don't want to do yourself, and that task has to be completed with a high level of dependability, almost perfect dependability, or it's more annoying to have help than it is to do it yourself. Okay, so in this context, let's talk about technology. The RIS and PACS replacement market is growing. The technology that was put in the 1990s has not really undergone a revolution yet. That's all old, fat client, meaning client server technology on premises. It's technology that's highly fragmented, that's difficult and costly to support, and that poses unacceptable security risks. Furthermore, it's technology that's going nowhere because you can't find modern programmers that want to program in ancient languages. In addition, it's the old technology out there today is not positioned to scalably implement and integrate AI in a way that is helpful to the reading physician. So RIS and PACS, the old will be replaced by the new. There is a huge pent-up demand to do it. Who's going to buy it? So in order to understand that, let's again take a little foundational diversion for a moment and talk about radiology groups and how they're structured and how that is changing. So at one time, most of the radiologists in the country were in independent groups. Today, we see mega groups appearing, often funded by private equity, where private equity may end up with 50% or more of the cash flow, coming into the organization. That's not always the case, and it doesn't have to be that way. Again, I'm making generalizations, and generalizations are risky. So take what I'm saying as general truth. Of course, there are exceptions to this. I don't want to offend anybody who is an exception. So there's independent groups. There are these growing mega groups, mostly teleradiology groups. And then there's the MSO staffing model, meaning you're a healthcare organization, maybe it's Kaiser Permanente or whatever. You have an affiliated medical group that employs radiologists and provides the management services associated with that employment. The independent group, the mega group, and the MSO staffing have models. They've traditionally, no matter which model you are in, well, let me rephrase that. If you were in an independent group, or if you worked directly for a healthcare organization, you probably participated in a RIS or PACS or reporting technology buying solution, but you didn't make the decision and you didn't pay for it yourself. Mega groups, beginning about 10 or 15 years ago, began buying their own PACS system. And what we're seeing today is in all three of these models, the radiology groups are becoming more and more empowered, and are, particularly in the independent group sector, are buying their own PACS system. And they're doing it because they have to do it in order to keep the group together. If the group can't read efficiently, if they can't hire radiologists for remote coverage, if you can't read at home or occasionally when you need to, even when you're on vacation, or in a very flexible cloud type structure, you can't hold the group together. The other thing that we're seeing is in the independent group, since about 1980, there was almost all private independent groups bill the patient separately. And whereas in the MSO staffing model, it's more common that the group, that there's a global bill sent to the patient and the radiologist is paid a salary plus bonus. The mega group, completely different structure. The typical teleradiology group, has billed the radiologist who wanted to sleep at night, and they billed on a per RVU basis. And there's quite a bit of variation with all of these. What they all share in common is, no matter the model, the organization with the most efficient and proficient radiologists and technologists wins. And so that's driving all three of these groups to become more active participants in technology buying decisions. Gone are the days of a radiology group kind of shrugging their shoulders and saying, the hospital bought an information technology system that is slowing me down. Too bad. Those days are over, because when you do that as a healthcare organization, the radiology group is more likely to just say, you know what, our group just fell apart because the 5 most efficient radiologists decided to leave and join another organization, such as a mega group or another independent group that has their own better technology. So look who's buying now. Today, as opposed to yesterday, even small and medium groups, even radiology groups of 3 people are buying their own SaaS solutions, because they're no longer is there a giant upfront cost. When you are a SaaS model provider of technology, you maybe have a small upfront implementation and training fee, but you're getting paid per report or per RVU or per case, however you define it, but your costs scale down for small groups. And so even tiny groups are buying their own PACS system. And that is a seismic shift in the way buying is being performed in this industry. On the other hand, hospitals, IDNs, independent imaging center organizations, they've always, archived exams. The PACS, the A in PACS is archive. And what we're seeing is more and more the technical provider of medical imaging services, the hospitals and the imaging centers, are buying their own cloud archive with a built-in business continuance solution so that they can change radiology groups or continue to function if the RIS or PACS is down. And that the modern cloud archive is just more cost effective than historical VNAs or PACS archives. Let's look at the economic model. So you're probably, if you're a radiologist or you're listening and you work for a hospital, the traditional model was the hospital or the imaging center owner, they bought the RIS, they bought the PACS. If you wrap in the hardware, internal support, and vendor costs, and the cost of money, because they're putting up a lot of money up front, they're spending $4 to $10 an exam. The radiology group says, this is great. The hospital provides all this technology that I get to use, just like they provided the CT scanner and the ultrasound device. It didn't cost me anything. And it didn't matter because the radiologists were not so acutely aware of the cost of suboptimal efficiency. Now they are. And it's obviously clear to you that if you have radiologists making $500,000 a year and you've got 20 people in your group, every time you lose 10% efficiency, you're losing $1 million a year. And more importantly, you're requiring 2 more radiologists than you otherwise would need, and they're not out there. So you're working more hours than you could possibly work. Hospitals also lose money by having suboptimal technology because it slows down the reporting of results to the emergency room. It slows down inpatient care. under the Medicare compensation system, keeping people in the hospital longer costs you money. It doesn't make you money. Typically in this model, buying decisions are slow and political. RFPs were the rule. 600-page RFPs were fairly common. And the more hospitals were involved in mergers and the bigger integrated delivery networks got, the slower the decision process was for buying and risks and PACS, and the more political that process is, and often things that are political are easily corruptible as well. So that's the way it's been. Okay. Today, what we're seeing is an IDN can buy a cloud archive that offers a business continuance solution attached to it, meaning an archive that has cloud reading capability attached to it, and reading and reporting, not just the viewing of images, but a true business continuance solution. That may only cost the hospital or imaging center owner 30 to 50 cents an exam, while it's sitting there as a backup system and an archive system. So it's far cheaper, it's far more cost effective today for a hospital or imaging center to take the position of, I'm going to own the archive, I'm going to own the business continuance solution, and it's going to cost me less money. In fact, it's going to cost me so much less money that I can go to the radiology group and say, and I'm going to give you a stipend of a couple of bucks a case. You buy and manage whatever reading system works best for your group. Because the hospital is still coming out, 40%, or in some cases, 75%, spending 40% or 75% less than they would have spent under the old model. And they end up with a radiology group that is stable, is in a position to grow. The RAD group is putting in technology, but getting a subsidy for it. So they're fine. If you can go out and buy a risk PACS reading solution for $2 a case, and the hospital's giving you $2, you're taking on some risk. And with that risk comes an incentive, but it's not out of pocket. You're not losing money on the deal. And in fact, every time you improve the efficiency of your radiologist by 10% in a 20-man group making $500,000 each year, you're picking up $1 million in value. And so this trend is exploding right now. And we're seeing large and small radiology groups doing this with the cooperation of their hospitals, who are eager to give up the political morass and costly maintenance of on-premises systems that in the end are not flexible enough to meet the local demands of the radiologists that are serving each of the facilities owned by the IDN or the imaging center group. The conclusion is everyone does better when technology makes the radiologists and techs more efficient, and that's really what this premise entirely hinges on. Does the tech really work? And this newer model really aligns the incentives properly, because the radiology groups are given control over what they need to, of the technology they need to do what they do, which is read exams quickly and proficiently. And the hospitals are given control over what they need to have, which is a secure storage of their medical images, reports, and an ability to keep business going if a radiology group decides to leave. So key trends, the power shift. The shift is away from hospitals and imaging centers buying to RAD groups buying the risk PACS reporting solution. We're shifting away from client-server architecture to a cloud architecture. We're shifting away from the old RFP system of political buying to more of a try and buy competitive situation. We're shifting away from a capital purchase where hospitals and rad groups had to put up a lot of cash up front to pure SaaS models with small implementation fees. We're shifting away from fragmented technology where risk, PACS, reporting, peer review, critical results, they were all separate systems to more unified solutions. We're shifting away from fragmented AI to tightly integrated AI inside of these cloud platforms. And we're shifting away from remote delivery of unencrypted PHI in these fat client solutions to a more secure environment where there is no unencrypted PHI remotely at rest required for there to be proficient remote reading. So with that, I will stop and thank you so much for your time and pause for any additional questions.
Yeah. Thank you, Dr. Reicher. Excellent presentation. We have a few questions from the audience. First one is, what steps need to be taken to have a hospital allow the radiology group to connect the radiology group's PACS to their modalities? Does it involve IT, cybersecurity, or something else?
I mean, first, it requires a relationship, right? So there has to be some trust between the radiology group and the hospital. Second, hospitals or the imaging center, whoever the technical provider is, if the rad group is going to provide the reading solution, that technology has got to be vetted for security, for performance, for scalability, also integration in with the hospital ordering system. If the hospital owns a VNA, you have to prove that that technology can work with that archive. If that same vendor is going to provide a cloud archive, then everything I've said in this lecture has to be validated. The imaging center, the hospital customer has to say, you know what, this new archive is that we're going to buy the archive end of the deal, and that archive has to work for us economically and technically, and the business model has to be vetted. So it's all of those normal steps, security, scalability, performance, lead the criteria.
Excellent, thank you. Are there any upfront costs with a SaaS? I know there's a lot of concerns with capital not being available and being able to work out of an operating budget versus a capital budget. Are there any upfront costs, and what are those upfront costs by using a cloud solution or a SaaS solution?
It varies from vendor to vendor, but the upfront cost should be much, much lower. Maybe, for a hospital, it might be in the $25,000 range. For an imaging center, it might be less. I'm talking about vendor costs. Again, you have to look at the marketplace and each vendor. The big advantage of a SaaS model, whether you're buying radiology software or accounting software, is you have the security as a buyer of knowing that you pay for what you use. And if you stop using it, you stop paying for it. That's very different than if in the old days, people would buy a PACS system, put up $1, $2, $3, $4, $5 million. That money's gone. And if you're borrowing that money from a bank, you're going to pay it to the bank whether you use the system or not. Today, I think buyers are they want to know that their costs are going to only scale up if their revenues scale up. And the SaaS purchasing model for all sorts of software has exploded because it just leaves the buyer in a more comfortable position.
Gotcha. And of course, in the past, when you bought hardware, by the time the system was finally installed and implemented, the value of the hardware was about half of what it was, what you bought it for. Here's our last question. Are there any issues with us, the radiology group reading from other sites, as long as the radiology group purchases the system, including the workstations? And then how do they prioritize what needs to be read? A lot of people, if they own the system, they feel that, you know, we should be number one. But now if the radiology group owns the system, they don't necessarily have that leverage. Can you comment on that?
Sure. Well, first off, the days of I have a radiologist parked in the hospital who only reads for this hospital. Is there any practice like that anymore? So there's a reality here. Radiology groups have gotten bigger and they cover multiple facilities. It used to be multiple facilities in the same region, but today it can be multiple facilities in far different time zones. That's just a reality of this marketplace. So in terms of priority, again, there's a contract between the hospital and the radiology group. In that contract, there should be and normally are service level agreements that say this is how long it should take to get a critical result read, a stat result, a trauma, a stroke. This is how many peer reviews we expect to be done. This is what we expect you to do in terms of critical results and critical test tracking. So that all gets negotiated in the arrangement, in the contract between the hospital and the professional provider. And then that leads to a set of system requirements. And to be successful in this marketplace, you've got to provide technology that meets all, so that the technology requirements provide solutions in order for the organizations to meet their business requirements.
Gotcha. All right, we had one more question that came in just now, and that is, what is the reliability of cloud services? Specifically, I know we have, Amazon, Microsoft, and Google as the three cloud service providers, plus the vendor themselves. Can you comment on the reliability of cloud services, at least what your experience has been up to this point?
Well, first, I give you a little historical perspective, right? I go back to the day of what is the, what's the reliability of electricity, right? Remember, we lived in a day when, the question was, what if my hospital network goes down? What if the hospital loses power? Is there some way to still, run films through a developer and hang them up with clothespins? So every time there's a shift in technology, we always go through a period of time where we feel very insecure because we're so dependent on the new technology and we're used to the old technology. But historically, the newer technology tends to, at least has, every time has been more reliable than the older mechanical, or manual technology that it replaced. And I think that's the same thing happening here on the web. So if you're a hospital or imaging center, you need a backup internet service provider. You just do. But if the Google Cloud went down or the Amazon Cloud went down completely, then you're talking, that's a whole different scale. And yeah, that would be bad. I'm not telling you it would be a good thing, but that becomes not just bad for your local hospital. That becomes, a regional war. Planes are not flying. Bank accounts are, not transacting. I'm not looking forward to that, and I'm not saying it could never happen, because it can happen. But you do have to come up with provisions to deal with it. But from a practical viewpoint, when you look at what's going to put your hospital at risk today in terms of providing medical imaging, the number one thing that's going to put you at risk right now is that there's no radiologist and there's no tech to do the work tonight. Yeah. Okay, that's going to be orders of magnitude bigger problem than Google and Amazon just went down.
Okay. Yeah, one of the comments that's been made is, AWS, Amazon has an east and west service, and some vendors have an agreement that if one goes down, they can switch to the other.
Yeah.
It's rare, but it has happened. But like to your point, I guess, dealing with someone the size of an Amazon or a Google or a Microsoft is a lot better than your local ISP. Again, can you comment on that?
That makes logical sense to me. I mean, that's where I would place my bet. I completely agree with that. Sometimes people feel that if they can control something locally, that they feel more secure. But you may feel that way. But I think that actually the reality is that we talk about organizations that are too big to fail. Some of these giant cloud service organizations have invested enormous amounts in their own reliability, and depending on it seems like a wise decision.
Yeah, I think the service providers are not the major issue. It's going to be the local connection up to the cloud from the service providers, and we'll see that, and that varies by area. If you're in a rural Montana, for example, it makes it's a little bit more difficult than if you're in, say, Orlando, Florida, where we don't rely on electricity, as we found out from our last two hurricanes. But we're not going to go there. I think that's it for questions at this point in time. Dr. Reicher, I certainly appreciate your presenting and giving us your great insight on this topic. For those attendees, we will have another webinar toward the end of January. The date and the topic have not been defined as of yet, but look for information on LinkedIn. We will post it on there. For those of you who participate in RadHQ, it will be on RadHQ as well. And with that, we will go ahead and end this presentation. Thank you all for attending. Dr. Reicher, thanks again for a great job.
Take care. Bye-bye.
Have a great one.